All right, for the sake of time, I think we're going to get going. So thank you to everyone who's joined today for the May edition of the NCS Pharmacy Section Journal Club. My name is Andy Webb. I'm the Neurocritical Care Clinical Pharmacy Specialist at Massachusetts General Hospital, and I'm honored to be the moderator for today's Journal Club. As a reminder, for those of you who have joined with us before, we have two presenters here who will be presenting two articles over the next hour. We would ask that you stay muted during the portion of the presenter's presentation, but feel free to add questions in the chat as the presenters go on. We'll address the questions at the end of each presenter's presentation. Also, we encourage you to follow along on Twitter. If you'd like to engage with the discussion on Twitter, make sure you use the hashtag NCSPharmJC, where hopefully the discussion will continue after each of the presentations. And so without further ado, I'd like to introduce our first presenter. Dr. Jason Patton is a PGY2 resident at the University Hospitals Cleveland Medical Center, who will be presenting our first article today. So Dr. Patton, I'll give the sharing over to you.
So thank you. So our trial today that we'll take a look at is the ceftriaxone to prevent early ventilator-associated pneumonia in patients with acute brain injury, also known as the PropyVAP trial. For some background, generally speaking, for overall incidence of VAP, it occurs in about 1 of 10 patients on mechanical ventilation, and that is variable across the literature depending on different risk factors that we'll see in the next couple of slides. But overall, VAP in general, regardless of the risk factors, once you have VAP, it's associated with an increased morbidity and mortality, as well as an increased overall hospital cost. So the mortality rate, again, depending on risk factors in the patient population, is anywhere from 10% and higher. And regardless, it results in a prolonged mechanical ventilation time, prolonged ICU stay, and then overall hospital length of stay as well. And as we'll see in the next couple of slides when we go through some of the preventative guidelines as well, the best treatment for VAP is prevention. And there's many different modalities to use that, as we'll see with the PropyVAP trial. One of the mechanisms is antibiotics, so we'll take a look at as well. When you think about overall risk factors for VAP, there are many. I highlighted a couple here that are significant. So the first ones are any patient that has pre-existing oropharyngeal or gastric colonization, and then immunosuppression and older age. For this population and for this trial, the main risk factor is impaired consciousness or brain injury. And this not only increases risk of VAP, the incidence is anywhere from 20 to 70% of patients that have an acute brain injury for VAP occurrence, but these patients also have a much significant higher mortality rate as compared to the general population as well. Also, when you think about VAP, there are sort of two different categories that you can think of in the microorganisms that are present between both. So the first one that is predominantly that we'll talk about for our trial, the PropyVAP trial, is early VAP. So in early VAP, you normally have just your oropharyngeal flora, versus your late VAP is when you get some of the more hospital-acquired pathogens such as Pseudomonas, MRSA, and then some gram-negative pathogens. There are preventative guidelines for VAP that were published in 2022, most recently by the Society for Healthcare Epidemiology of America, the IDSA, and then the Association for Professionals in Infection Control and Epidemiology. And there's a lot of different recommendations that they have. I highlighted some of the most prevalent and most pertinent here, and they're divided into 3 different categories. So the essential practice, additional practices, and then those that generally aren't recommended. Looking at the essential practices that have evidence to decrease time on the ventilator, length of stay, or mortality, the recommendations are to provide early enteral versus parenteral nutrition, minimize sedation, so having some sort of sedation weaning practices, maintaining physical therapy for patients, oral care with toothbrushing without chlorhexidine specifically, and then head of bed elevation to 30 to 45 degrees. As far as other practices that may benefit these patients in a certain niche population, but may infer harm in other populations, is the use of selective oropharyngeal decontamination or selective decongestive tract decontamination in ICUs with low prevalence of antibiotic resistance, early trach, and then post-pyloric feeding. And then you can see some of the recommendations. One of the ones that I highlighted here that are not recommended that may impact patients negatively or infer some sort of harm would be oral care with chlorhexidine, as it has been evaluated in other trials and meta-analysis that may infer harm for these patients. So you might be asking yourself, what about antibiotics? The guidelines really do not mention them. The only time antibiotics are mentioned in the guidelines is when it comes to some of the trials for the SDD and the SOD. Some of those interventions did use antibiotics, so we'll take a look at. But overall, generally, antibiotics aren't mentioned for preventative patients for VAP. In terms of literature, there's four main trials that I wanted to highlight. The last two here came out very recently, right around the same time as the PropyVAP trial that we'll look at. The first one was in 2019 called the Antarctic trial that enrolled just under 200 patients, and they wanted to look at mechanically ventilated patients following out-of-hospital cardiac arrest. And they utilized IV amoxicillin clavulanate versus placebo within 6 hours after cardiac arrest for 2 days. Their primary outcome was early VAP, specifically within the first 7 days of ventilation. But overall, they found they found a lower incidence of early VAP compared to placebo, but did not find any difference in their secondary outcomes, such as late VAP, ventilator-free days, mortality at day 28. The next trial, the SUD ICU trial in 2022, had just under 6,000 patients, so a very large trial. And they wanted to look specifically at mechanically ventilated patients in the adult ICU. They were anticipated to have mechanical ventilation for at least 48 hours. The intervention was gastric suspension and an oral paste for every 6 hours, and that paste and the suspension contained colistin, tobramycin, and nystatin, in addition to IV antibiotics for 4 days, which the supplementary listed as either third-gen cephalosporin or ciprofloxacin, as opposed to standard of care. The primary outcome for this trial was in-hospital mortality within 90 days. They found no reduction of overall mortality for these patients, as well as no difference in their secondary outcomes as well. However, this led to a post-hoc analysis of the patients of this trial, specifically in the neuro population. So they looked at all patients from the SUD ICU trial that had cardiac arrest, ICH, subarachnoid hemorrhage, stroke, brain infection, a neurologic neoplasm, seizure, subdural hemorrhage, and then a traumatic brain injury as well. And they wanted to see for this patient population if this intervention had any benefit for them. What they overall concluded, there was a significant difference in hospital mortality, a reduction for these patients using the selective decongestive tract decontamination. And then as far as their secondary outcomes, they also found decreased ventilator-free days, and then also days alive free of ICU admission. And then the last trial we'll talk about was also recently published in November, called the Amican Hall trial in 2023, that looked at patients, again, undergoing mechanical ventilation, all patients specifically to receive the inhaled amikacin for 3 days versus placebo. And then again, this trial did find a reduced burden of VAP at 28 days, but there were no difference in mortality or days of antibiotics. So essentially what you can see from all of these trials, there does seem to be a trend towards decreased incidence of VAP. However, the secondary outcomes that some of these trials looked at are still to be determined as far as length of stay outcomes, but there does seem to be a benefit in potentially the neuro population. So that brings us to the PropyVAP trial that wanted to specifically look at an effect of early single-dose ceftriaxone on the incidence of early VAP in patients with severe brain injury requiring mechanical ventilation. The study was a multi-center, randomized, double-blind, placebo-controlled trial that was conducted across 9 different ICUs in 8 hospitals in France. They included patients greater than or equal to 18 years of age, patients with a GCS less than or equal to 12, specifically as a result of an acute brain injury, which they defined as head trauma, stroke, or subarachnoid hemorrhage. Patients specifically had to be intubated via the oral route, and then had to be predicted to require mechanical ventilation for more than 48 hours. Some of their exclusion criteria: any coma that was due to a tumor or infectious disease or cardiac arrest, patients that were at high risk of death within the first 48 hours of admission, any patient that was continued or previously on antibiotics at the time of enrollment, any patients with a hospitalization within the last month, any patients that were anticipated to be on antibiotics within the first 24 hours, and then any patients with an allergy to beta-lactams. Patients were then randomized in a 1-to-1 ratio, and then they were stratified by the center of enrollment, and then also by their Glasgow Coma score, less than 8 or greater than or equal to 8, to receive a single dose of IV ceftriaxone 2 grams or placebo for 1 dose. And then, as we mentioned, there are a lot of different preventative measures for VAP. So the authors did mention for this trial that across all the different ICUs, all the different trial sites, before enrolling patients, they routinely implemented either hand washing, head of bed elevation, mouth care every 8 hours without chlorhexidine, preferential oral insertion of feeding tubes, early enteral feeding, and then stress ulcer prophylaxis. And the authors did mention that it was not recommended for any of these sites to use SOD or SDD prophylaxis measures for these patients. The primary outcome was early VAP, specifically from day 2 to 7 of mechanical ventilation. And the secondary outcomes were late VAP, all VAP, the time to first VAP, the different pathogens that were isolated for these patients, ventilator and antibiotic-free days, modified Rankin score, and then mortality. As far as the VAP diagnosis, I wanted to highlight for these patients, they used the American Thoracic Society criteria. However, it was slightly different. They did require patients to have all three, so clinical, radiologic, and microbiologic data. So patients had to have two of the following to meet the clinical criteria. They had to have new consolidation on imaging and then also a positive sputum culture. And then all diagnosis for VAP was confirmed by an independent adjudication committee by two senior intensivists that were masked to the study intervention group. For statistics, they utilize an adjusted Cox model that adjusted for a competing risk, so death before VAP, and then also ventilator weaning. And then they estimated a 30% incidence in the control group and the ceftriaxone group to decrease incidence of VAP by 50%, so a 15% occurrence rate. Looking at results, just over 2,000 patients were screened from a 5-year period up until 2020. With those 2,000 patients, 345 were then randomized, and then 319 patients included. As far as pertinent exclusion criteria, just over 700 patients were excluded because they either received or were expected to receive antibiotics within 24 hours. So almost half of the patients were excluded for this reason. And then looking at baseline characteristics, there weren't any significant differences really between either of them. Just to highlight some of them, the mean age was just over 56 years old, predominantly about 50 split between male and female. BMI was around 26. And then as far as the mechanism for brain injury, about 10% was from an ischemic stroke, just over 20% for a hemorrhagic stroke, around 40% for a subarachnoid hemorrhage, and then around 30% for a brain trauma. Looking at some of the other baseline characteristics, again, no stark difference between them. You can see for a GCS score 4 to 8 was the predominant amount of patients that were enrolled at about 60 to 65%. They did report a SAPS-2 score, which is similar to a SOFA score or an Apache score as far as illness severity. And the mean score was around 47, which correlates to a mortality of about 35 to 40% predicted. The time to intubation was about 1 hour, and then time from intubation to treatment, 7 hours. And then mostly all patients were afebrile at the time of enrollment. That brings us to our primary outcomes. So you could see a significant difference between the ceftriaxone group and the placebo group. Early VAP occurred in 23 patients in the ceftriaxone group, or 14%, versus 51 patients in the placebo group, or 32%. That is also demonstrated by the cumulative incidence curve here. And I also wanted to mention here that the authors did report in the supplemental material. I mentioned how they had the adjudication committee. They did note that 42% of the cases that were initially reported by the investigators as VAP were subsequently not confirmed after adjudication. So I did just want to make a note of that. And then looking at secondary outcomes, you can see they divided them between secondary outcomes up until day 28 and then those up until day 60. And you can see a significant difference in all VAP for patients in the ceftriaxone group, late VAP and ventilator-free days, antibiotic-free days, time to first VAP, modified Rankin score, and then also mortality. All were significantly reduced in the ceftriaxone group. Looking at outcomes up until day 60, you can see a difference for ICU-free days and then also hospital-free days. However, there was no difference in modified Rankin score or mortality at day 60 for these patients. For some other outcomes they reported that I wanted to include, looking at adverse events, Just to note, they did not mention how they distinguished between pneumonia as being an adverse event or not, but I did want to include that here. You can see a similar incidence between both groups. And then other things such as C. diff or multi-organ failure were pretty similar between both groups. However, there wasn't high enough incidence to run statistical tests on. Looking at the pathogens were isolated, wanted to highlight some of the differences. So looking at H influenza for patients, there was 0 incidence in the ceftriaxone group versus 17 in the placebo group, which was pretty significant between the two. And then also methicillin-sensitive Staph aureus occurred in 7 patients in the ceftriaxone group versus 25. Everything else was relatively similar between the two groups. As far as the author's strengths for this trial, they mentioned it was a large multi-centered randomized controlled trial, and compared with some of the previous trials that we looked at, was a simple intervention as the one-time dose of ceftriaxone. Also mentioned as a strength was the central adjudication committee that they utilized to confirm the VAP diagnosis. And then overall, compared to some of the other trials, they utilized more patient-centered outcomes that had an external validity specifically for brain injury patients. Some of the weaknesses the authors noted was they did not monitor the VAP preventative measures, even though they instituted them across the different ICUs before enrollment, they did not measure them during enrollment. They did not monitor any of the digestive tract modifications to the microbiota that may have occurred for these patients, as well as any effects on overall healthcare associated infections. This led the authors to conclude that early administration of a single ceftriaxone dose decreased the overall risk of VAP, exposure to ventilation, exposure to antibiotics, prolonged ICU stay, and also mortality without any significant safety concerns. Some critiques and some components that I wanted to highlight. The first being the early VAP diagnosis as a primary endpoint. This is an endpoint that could be somewhat skewed against the ceftriaxone group when you think about those patients did receive antibiotics before diagnosis of VAP, and the sputum culture was required as diagnosis for VAP. And this especially is reported when you look at the 42% of cases that were initially reported by the investigators that weren't then subsequently confirmed. And that may be something that the early dose of ceftriaxone may have prevented the utility of the sputum culture for some patients. Other things, when you look at the secondary outcomes, again, they're mostly hypothesis generating since it wasn't powered to test for those exactly. And then also when you look at the overall mortality decrease for patients, it was about 10% in the ceftriaxone group. When you look at overall VAP mortality, it's only around 10% in the literature. So there may be some external factor that may have influenced overall mortality for patients in the ceftriaxone group. And then in external, as far as external validity, I do agree with the authors as opposed to some of the other trials that were a lot more significant interventions, more frequent interventions, and for multiple days. This was much simpler in the fact that it was a one-time dose. However, when you look at some of the exclusion criteria, almost half of the patients were excluded because they were anticipated to use antibiotics within the first 24 hours. And then there also wasn't any criteria listed as far as the exclusion for patients that were either at high risk of death within the first 48 hours or patients that required mechanical ventilation for 48 hours. They did not exactly parse out the specifics for those patients. And then again, it was also conducted in France. So as far as microbiota data, it's slightly different here in the US as well. In terms of some of the critiques and potential relevance for antimicrobial stewardship, besides making some of our ID colleagues cringe at the thought of this, I wanted to kind of pose a question. So is the role of antimicrobial stewardship to decrease the total antibiotic use, or is it to decrease the total number of patients exposed? I think when you look at this trial, it definitely did decrease or has a potential to decrease the overall antibiotic use, as if you're preventing VAP, you would prevent these patients from having, 7 to 10 days of potential broad spectrum antibiotics. However, when you think of it in terms of the overall number of patients exposed by implementing something such as this trial, you would expose a lot of patients that otherwise would not need antibiotics during their hospital stay to antibiotics. And again, with that, the long-term effect on antimicrobial resistance is not known. And then I did want to highlight some of the other thoughts for antimicrobial stewardship in terms of the overall reduction in broad spectrum antibiotic use. They did report this in the supplementary appendix. And I specifically highlighted those that received either Pseudomonas or MRSA agents here. So you can see not too big of differences when you look at overall broad spectrum antibiotic use. You can see 5 versus 10 in the placebo group for amikacin, slight increase in other drugs such as linazolid. But when you look at, say, piperacillin tazobactam, for example, where there was actually a higher use in the ceftriaxone group as compared to the placebo group, and then not too big of a difference between vancomycin versus placebo as well, which I did want to highlight as far as the overall antimicrobial stewardship for this as well. Overall conclusions, I think you can conclude from this trial and then as well as subsequent trials that early administration of antibiotics in this trial, ceftriaxone, specifically in brain injured patients, does reduce the diagnosis of VAP. However, the overall application for that, I think, still is yet to be known. However, from this trial, I think it does have an area of potential use in patients that may have been at high suspicion for aspiration at the time of intubation. And then I think it also is a good argument for not using broad spectrum antibiotics initially for these patients if there is a suspicion for aspiration upon ventilation, because I think it does show that ceftriaxone was significant for these patients. However, next steps before large scale implementation, I think you do need trials with longer term follow-up that monitors antimicrobial resistance for these patients, not just at one study site, but across the different study sites as well before any large scale implementation. For my references, and I would be happy to answer any questions.
Fantastic presentation. Thank you so much for going over the details of that trial. For the audience, feel free to either unmute yourself if you have a question you'd like to ask, or feel free to drop your question in the chat. But I would like to start by saying I'm curious what your institution does for that prophylaxis, if anything at all, and whether or not the results of this trial are compelling enough for you to try to advocate for early prophylaxis with antibiotics.
Yeah, so we have not changed our practice yet. I think in terms of different groups, so you sort of have your ID colleagues and then your neuro colleagues as well. I believe probably from an ID standpoint, I don't see them ever proposing this as an option. I think it would have to come probably from neurology first. But as far as our specific institution, that has not happened yet.
Yeah, likewise. So we here at MGH don't even do chlorhexidine prophylaxis. We just kind of do nursing-driven mouth care with toothbrushing and those sorts of things for prophylaxis. And so it'll be interesting to see how the evidence kind of evolves, given the fact this is not the first study that's suggested there may be a benefit here. I'm curious your thoughts. Other trials have looked at antibiotics and for prophylaxis and have particularly shown a reduction in the kind of microbiologic diagnosis of VAP, which isn't particularly surprising given the fact that likely is going to sterilize some of the sites of culture. But this is kind of the first trial that has seen more clinical benefit in terms of fewer days on vent and fewer improved mortality at hospital discharge. Kind of curious to hear your reactions to almost how realistic you think that effect size is, or what other things may be kind of driving that effect.
Yeah, I think it's interesting for this as opposed to other trials that you mentioned, as far as the other trials didn't really find any difference for the other more clinical outcomes, I guess, besides just diagnosis of VAP. When you look at the SUD ICU trial, the post hoc analysis, they did see a difference for some of them for acute brain injury patients, but again, they were using an intervention for over 4 days versus this was just 1 day. I think from a pharmacokinetic standpoint, it is hard to say that the one-time dose of ceftriaxone initially, even though it does have a longer half-life of 24 hours, would affect any antibiotics or any VAP diagnosis, I guess, or colonization for patients, 3, 4, 5, 6, 7 days during hospital admission. So I think it is hard to argue as far as how that could have occurred for these patients, that they did have a difference in overall outcomes. I think one of the things that was interesting, though, when you do think about that, is the overall diagnosis of VAP. It was not confirmed for 42% of patients that were initially confirmed based off the investigators, and they only looked at patients that were diagnosed with VAP. So it is curious as far as patients maybe that weren't diagnosed with VAP initially, like during the confines of this trial, that maybe had a later signal. That would be the only thing that I would think of. But other than that, it is sort of hard to argue against the use, I guess, at this point, as you did say, there is 2 trials now that does show benefit for these patients.
Yeah, and I think you bring up an interesting point. It's always surprising with these trials how many cases of VAP are deemed to not be VAP by the trial investigators. And that's something that I think is that kind of being increasingly recognized in the literature, just how hard it is to diagnose a true pneumonia and how often we get it wrong. I guess one last question for you. You may have mentioned this, but I'm just curious if you could remind the audience, how did the investigators determine whether or not a patient was likely to stay intubated for 48 hours or longer? And I think thinking if you're trying to operationalize this, it'd be hard to decide whether you just universally give a dose of ceftriaxone or if there are actually objective criteria versus just clinical suspicion. That's going to be the case.
They did not. They had two different criteria. So those that potentially had mortality within the first 48 hours or expected mortality, and then those that was one of the exclusions, and the inclusion obviously for to undergo mechanical ventilation for at least 48 hours. I could not find. I looked through the supplemental, and then there was also a previous, I guess, pre-trial protocol for this, and I think it was like in like 2019 or 2020 that they had sort of their methods as well. And I don't think they mentioned in either one of those as far as how they included patients or how those patients would meet criteria for that. So unfortunately, I'm not sure.
Yeah.
It would be interesting to know.
Yeah, I was curious too. I wasn't sure if you're able to find it. Or like, if this were to become something that centers start to operationalize, I think kind of defining those criteria will become important. And then there's just two final questions in the chat that we'll pose to you before we transition to our next speaker, both from Josephine. The first one is, if you were to redesign the trial, what would you suggest doing differently? And second, would ceftriaxone be an appropriate initial prophylactic choice for all patients?
So I guess this second part first, as far as is this an appropriate agent? I think in terms of ease of use, it definitely would be. When you look at some of the other trials, they were doing mouth care every 6 hours, IV antibiotics for 3 days. I think this would be a simple intervention that you wouldn't miss doses. You just do a one-time dose, and it would be a pretty much catch-all. I think when you look at its terms, when you look at their microbiologic data as well, they didn't really have high incidences of Pseudomonas or MRSA or anything like that for the first 7 days for these patients. So I don't think you would need more broad spectrum antibiotics. So I think ceftriaxone would be fine. Other options you could potentially consider, again, would be like Unison, other options like that would have similar coverage, but again, that's multiple doses per day. So I think the one-time dose would be appropriate. As far as to redesign the trial, I think the biggest thing would be the primary outcome. I think you can probably keep their inclusion exclusion criteria the same. I think they did hit for a majority of patients in the neuro ICU population. But I think as far as the outcome, like we mentioned, there is such vagueness and variance between diagnosis of VAP. I think utilizing an endpoint that would be a little more less dynamic for these patients. However, you would have to enroll a lot more patients to show significance for that. However, I think for an overall surefire implementation for this intervention, I think you would need some sort of concrete evidence besides something up to interpretation for such as diagnosis.
Fantastic. Thank you so much for addressing all those questions. I think a lot of us are kind of waiting for a little bit more evidence before we're quite confident enough to implement this into our practice. But this is certainly a very provocative study given the degree of positivity of their primary outcome. So thank you so much, Dr. Patton. Really appreciate your presentation. And we will transition to our second speaker. So Dr. Marissa Saber is a PGY2 critical care resident at Yale New Haven Hospital, who will be presenting an article on dexmedetomidine use in traumatic brain injury.
Okay. Can everyone see my screen okay?
Yes, we can see it.
Beautiful. Okay, great. Thank you. So thank you for the warm introduction. My name is Marissa Saber. I'm a current PGY2 at Yale New Haven Hospital in critical care. And today I will be discussing the association of early dexmedetomidine utilization with clinical and functional outcomes following moderate to severe traumatic brain injury. And it was a transforming clinical research and knowledge in traumatic brain injury study. So our objectives for today include reviewing the current recommendations for analgesia and sedation in traumatic brain injury, and then also assessing the use of dexmedetomidine for moderate to severe TBI. So first, we'll start off with a brief review of the basic pathophysiology of traumatic brain injury. It begins with an initial insult, which causes reduced cerebral blood flow, leading to neuroinflammation. Neuroinflammation is one of the key mediators in maintaining our cerebral perfusion pressure, known as our CPP. CPP is calculated by subtracting the intracranial pressure from the mean arterial pressure, or the MAP. As the ICP increases, like it does in TBI due to injury, the CPP will be reduced, and then this will cause secondary cerebral ischemia and infarct. This will then bring us to our main goal of management, which is to prevent secondary insult. One way we prevent secondary insult is by reducing the amount of neuroinflammation and limiting the increase in ICP. So next we'll review how we can do this as mentioned in the Brain Trauma Foundation's Guidelines for Management of Severe Traumatic Brain Injury. So the guidelines offer ways for ICP to be managed both medically and surgically. The most recent updates to the guidelines in 2020 recommend secondary decompressive craniectomy in those with late refractory ICP elevation, but not those with early refractory ICP elevation. Placing an EVD is also useful in physically removing CSF to help reduce ICP. And the guidelines also mention using mannitol specifically and monitoring with serum osmoles for drug accumulation. While not specifically mentioned in the 2017 brain trauma guidelines, hypertonic saline has also been mentioned in other ICP lowering guidelines and is commonly used in clinical practice. Steroids are not recommended, and it has been shown that high-dose methylprednisolone was associated with increased mortality in our TBI patients. Another way the guidelines recommend to manage ICP is through sedation. So sedatives have been reported to improve intracranial pressure by reducing the cerebral metabolic rate, or the CMR. It also reduces cerebral blood flow and volume. So typically this is done either through a midazolam or a propofol infusion, which propofol tends to be the most common primary sedation agents for these patients. And you'll also see this in the study today. Propofol was the most common agent. The guidelines here mention using propofol. However, they note that there have not been any studies showing improvement in mortality or 6-month outcomes. So similar to the studies that we are reviewing today, there have been other studies looking at early sedation, but instead of using dexmedetomidine, using propofol or midazolam in TBI patients. And so far, there has not been any improvement in in-hospital mortality that has been found. So now we'll focus on our study drug, dexmedetomidine, and let's just take a brief glance at the guidelines, and where, as you can see, there's nowhere highlighted on the slide dexmedetomidine being mentioned. So why do we use it, and should we even be using it at all? So to briefly review the mechanism of action of dexmedetomidine, we know it's a selective alpha-2 agonist, but how does this help with neuroinflammation? The dexmedetomidine is now being studied for its organ protective effects across the body, not just with neuroprotection. It has been shown to have anti-inflammatory properties to help reduce interleukin and TNF-alpha. It also promotes protective signaling to reduce neuronal damage incurred by ischemic hypoxia. Finally, one of the new mechanisms that is being studied is its effects on autophagy. This is an adaptive catabolic process that helps to maintain cellular homeostasis by recycling. So it engulfs cellular targets, including damaged organelles, unfolded proteins, and pathogens. During an event like TBI, this process can wax and wane depending on the stage of illness that the patient is in, and they found that dexmedetomidine has been shown to alter the response to be more beneficial to the patient. So with all of these proposed mechanisms of benefit, it was thought that dexmedetomidine could potentially help with mortality. As you can see from this retrospective cohort from 2022, looking at around 2,600 patients with TBI, intracranial injury, or skull fracture with loss of consciousness, there was a benefit with dexmedetomidine in reducing in-hospital deaths and deaths at 6 months with a hazard ratio of 0.16 and 0.13 respectively. This study looked at all severities of TBI and did not differentiate between mild, moderate, and severe, which is different from the study we're discussing today. In the baseline characteristics, the APS-3 score, which gives you a percentage of in-hospital mortality, meaning the higher the number, the worse the outcomes. This was higher in the dexmedetomidine group at 42 in comparison to the control group, which was 33. However, this difference was found to not be statistically significant. This is in comparison to our study, which looked at moderate to severe TBI only. In addition, dexmedetomidine was still relatively new at the time and expensive at the time of these data sets, which could have influenced how they were using the drug. So we also have newer studies from 2024 that have looked to continue to prove this benefit. And a retrospective cohort that was published in February of this year by some of the same authors of the article we're discussing today. This study found dexmedetomidine used within the first 2 days of hospitalization for at least 2 days decrease mortality and hospital length of stay. This study looked at just under 20,000 patients from the premier data set and defined moderate to severe based on the head and neck abbreviated scale. You'll find that this study had some major differences in comparison to the study that we're discussing today. Two that I wanted to point out include what they defined as early dexmedetomidine use, which had to be used within the first 2 days of hospital admission. This is in comparison to our study, which was defined as dexmedetomidine use in the first 5 days. Also in this background study, patients were initially grouped into moderate or severe based on their AIS score, which is based on the anatomical region of where the trauma in the body occurred, and typically uses neuroradiologic or operative findings. And in the study we're discussing today, patients were grouped into moderate or severe based on their Glasgow Coma score. In the background study, patients had to have an AIS score between 3 to 5. And in the study we're discussing today, the mean AIS score was 3.8 with a standard deviation of 1.2. So this highlights the need for our TBI studies to help better standardize our results, to help use one grading scale to help define mild, moderate, or severe, to help us better compare the studies. So like I had mentioned, the AIS scale is different than the scale in the study we're using today. So in our study for today, they use the Glasgow Coma scale the Glasgow Coma scale to help define severity. And then we use the Glasgow Outcome Scale extended to assess function in a patient after the injury. So a score of 5 to 8 is considered good functional outcome, where an improvement in scoring is defined as an improved clinical outcome. So jumping up from 6 to 7 or 5 to 7 would be considered an improved clinical outcome. So now that we have our background information, let's begin discussing our article for today, Association of Early Dexmedetomidine Utilization with Clinical and Functional Outcomes Following Moderate to Severe Traumatic Brain Injury. So this was published in the Critical Care Medicine Journal in April of 2024, so just about a month ago. The study was a retrospective cohort using data from the TRACK TBI database from 18 level 1 trauma centers in the US. The TRACK TBI database has collected and analyzed detailed clinical data on subjects from February of 2014 to August of 2018. And it includes information on injuries, CT, MRI imaging, blood biospecimens, and detailed clinical outcomes. Patients who were included were those with a moderate or severe TBI based on their Glasgow Coma score, admitted to an ICU, and were mechanically ventilated in the first 24 hours. They were excluded if they had incomplete medication records, unknown time to extubation, and death within the first 48 hours of ICU admission. After inclusion and exclusion criteria was placed, they looked at patients to see if they had been on a dexmedetomidine infusion within the first 5 days of ICU admission, and they called this early dexmedetomidine use. They then measured the time on infusion as the start of the infusion until the first gap in therapy lasting at least 4 hours. And I briefly want to mention at this point of time, dexmedetomidine had been approved for use for about 15 years, and it was available as brand name only until 2018. So the tail end of this data set caught when dexmedetomidine had gone generic. The outcomes that they chose for this patient population were appropriate. In this study, the primary objective focused on clinical and functional outcomes in comparison to the previous studies mentioned earlier and the background information that focused more on mortality. And then secondary outcomes for this trial included ICU length of stay, hospital mortality, 6-month disability rating scoring, and finally 6-month mortality. So they made sure to still include mortality when looking at the outcomes, but it was not the main focus of this trial. Appropriate statistical analyses were run and well detailed in the article. They used Mann-Whitney tests for continuous variables and Fisher-Exact tests for categorical variables. It attempted to reduce as much bias as possible by using propensity weighting when comparing the two groups. It also included a post hoc analyses, which we will discuss the results of later on. And while a post hoc analyses can't bring us to a final conclusion, it can help us to generate ideas for future studies. Okay, so now let's get to the most exciting part of the study, the results. First, we have our baseline characteristics, and these show that the first sedative used in most of the cases for the patients was propofol. From there, looking at the mean number of sedatives, most patients were either on one in the non-dexmedetomidine group, so likely these patients were just on propofol, or two in the dexmedetomidine group, propofol and dexmedetomidine likely. Further diving into the supplementary data, this shows that this was likely institution specific on if they used dexmedetomidine or not. In addition, this shows that in our patient population, dexmedetomidine was being used as an adjunct to sedation. Patients in both groups were fairly young, with a higher percentage being males, similar to what we'd expect in a trauma population. Both groups had a variety of injury types, which likely represents similar to what we would see in our hospital here, being a level 1 trauma center. So this is all appropriate for what we would expect. Finally, to wrap up our patient population results, both groups had a majority of severe patients, and about 20% were so severe that they received ICP lowering therapy in the emergency department. This further emphasizes that the patients that they were looking at and focusing on were quite sick on admission. So now that we understand our patient population and the patients being treated, let's assess our primary outcome, which is looking at clinical and functional outcomes through the Glasgow Outcome Scale. Here we can see the distribution of the two groups. As shown by the results, there was no difference in clinical improvement or functional improvement in either the unweighted or the weighted groups. Even by just visually looking at the bar charts, especially looking at the weighted groups, you can see how similar the two look and almost look the exact same. The authors then took the results one step further and broke the patients up into two groups based on if they needed ICP monitoring or not. They ran this post hoc analyses with the hopes that they could target a sicker patient population by looking at those requiring ICP monitoring. Results of the post hoc subgroup analyses found that those who required ICP monitoring and received dexmedetomidine had a higher Glasgow outcome score, therefore improving the clinical results. In addition, they also had more patients with a favorable score, which was statistically significant. And just as a reminder, post hoc analyses are hypothesis generating only and don't really support clinical practice changes. In our secondary outcomes, I wanted to highlight where we found statistical significance. So they did find this in the 6-month disability rating scale in both the unweighted and the weighted groups. The 6-month disability scale looks at a patient's arousal and awakeness, cognitive ability to handle self-care functions, physical dependence, and psychosocial adaptability. In the case of the patients using dexmedetomidine, they found that these patients had lower scores, meaning they had lower ranges of disability. The lowest score possible is 0, meaning no disability, and the highest score is 29, meaning severe possibility. And then finally, to round out our results, here we have the difference in 6-month survival. Unlike the background studies, there was no statistically significant difference in survival. And this further adds to the debate on if dexmedetomidine is beneficial for mortality in our TBI patients. However, this really was a limited number of patients, and there are more factors to keep in mind when assessing the study, which we'll talk about when we assess its strengths and weaknesses. So overall, the author concludes that early dexmedetomidine exposure was not associated with improved 6-month functional outcomes as defined by the Glasgow outcome scoring of 5 to 8. However, dexmedetomidine may provide clinical benefit as defined by improvement in Glasgow outcomes scoring in those patients with indications for ICP monitoring. So while the author's conclusion described benefit for using dexmedetomidine in certain TBI populations, it's important to consider both the strengths and the weaknesses of this trial. So for example, one of the strengths that I identified was that the authors did recognize one way to focus on sicker patients was to look at those requiring ICP monitoring. In practice, we can monitor ICP via the EVD, showing that these patients were likely severe enough to require a surgical modification to decrease their ICP. I thought it was also beneficial to focus on quality of life outcomes in addition to the studies that we already have focusing on mortality. With an injury as severe as TBI, this will likely change a person's life, and it's important to think about ways to support a meaningful life in addition to improving mortality. Lastly, they appropriately recognize to help the benefits of matching the patient population between the two groups to help reduce bias. So while propensity-weighted scoring helps to account for some of the covariates, there will always be some bias due to the retrospective nature of the trial. So this brings us to one of our weaknesses. In an ideal world, this would have been completed as a randomized, controlled, double-blind clinical trial. In addition, one of the other weaknesses was that dexmedetomidine was typically used as a second-line agent. We know that our other sedatives, like propofol and midazolam, are also used to decrease ICP, and also being studied to see if they improve mortality as well. So this can cloud the picture of if it was actually dexmedetomidine providing the clinical benefit or not. So going back to our ideal trial, these patients would be maintained on dexmedetomidine only to see if it would be beneficial on monotherapy, or eventually would have required other sedative agents to help reduce ICP in addition to the dexmedetomidine. So at the time of the patient dataset, dexmedetomidine was brand name only for most of the time period, as I had mentioned. This potentially limited usage, especially if there were certain restrictions put in place as a cost savings measure, due to the fact of potentially it was only used for 24 hours to help reduce costs. And the final weakness I wanted to mention was, again, how they defined early sedation. In this case, 5 days can be a lot of time for a patient to recover. If you look at the supplementary data, the patient was only on dexmedetomidine for a median time of 15 hours, which is really not that long, which could go along with a theory of limiting dexmedetomidine use due to cost savings. So this leads me to believe that we potentially don't know if dexmedetomidine was on long enough to help reduce neuroinflammation and reduce sympathetic activity. For example, it could have just been used acutely to help facilitate extubation on day 5 of the admission and was likely not helping with neuroinflammation at that point in time. However, if they would have limited it to dexmedetomidine use within the first 2 days, we likely would have only had a very small patient population. So as limiting it to only the first 5 days only yielded a total of 77 patients. So we're stuck between a rock and a hard place with the data set that they had used as the TRACK-TBI data set. So overall, putting the results together and keeping in mind both the strengths and the weaknesses of the study, it found that dexmedetomidine is commonly used as a second-line agent for sedation in TBI rather than first-line. Dexmedetomidine use in patients undergoing ICP monitoring has shown promise in improving clinical and functional outcomes. However, more studies are needed to confirm. And then lastly, further RCTs are needed to assess if dexmedetomidine is beneficial as first-line sedation to improve clinical and functional outcomes. And this concludes my presentation on dexmedetomidine in TBI patients, and what questions can I answer?
Fantastic presentation. Thank you so much for bringing us through that data. A lot of these TRACK-TBI studies are quite interesting to kind of look, at practice pattern variation across centers and whether or not some of the small details of care really do have meaningful impacts on our patients. So as with our previous presenter, feel free to drop any questions you may have in the chat, or feel free to come off mute if you'd like to share it with our presenter directly. I think the first question that I had for you is you make a great point that during the study period, dexmedetomidine was brand name only. And so there's a chance that dexmedetomidine use may be skewed to centers with higher resources. So I'm curious if you managed to see whether they adjusted for any treatment center effect, meaning, did patients at larger academic sites have more resources put into them and maybe that influenced their outcomes versus the dexmedetomidine itself?
Yeah, so looking at the list of the hospitals that participated in the TRACK-TBI data set, they were all like major level 1 trauma centers, typically associated with like a large academic medical center. So like University of Kentucky, a lot of hospitals in Boston were involved. So places that you would expect to have like a decent amount of funds to provide dexmedetomidine use to their patients. However, they did note that they did not, when they were putting together the propensity weighting scoring for the two groups, they did not include this as one of their variables, so that like further broke it down when they were looking at the two patient populations.
Yeah, awesome. Thank you so much for that. I'm always curious with these medication exposure studies if the medication exposure is just a proxy for where the patient's taken care of. So it's good to hear that at least they had some consideration of that, particularly just in the centers they included. I guess my next question for you is whether or not you can kind of think of whether there's a mechanistic link between the potential improvement functional outcomes that, as a post-hoc analysis for patients with ICP monitors in place.
So I think potentially we see it with dexmedetomidine use, we typically think of it as reducing sympathetic storm and storming in our TBI patients. So this could potentially help decrease the ICP as well. I think the neuroinflammation pathway that they're sort of investigating more and looking into will be really interesting, as they've seen it in a lot of animal studies so far, but I feel like animal studies don't always translate into what we see in real world studies. So I think that has potential to decrease ICP. I'm not sure if it will be to the extent of like propofol and midazolam, just due to the amounts of sedation you can get with those two agents and compared to dexmedetomidine. But I think it would be really beneficial to see like dexmedetomidine only in a clinical trial in these patients to see if they would derive more benefit.
Did the authors report cerebral perfusion pressures between the two groups? Because it's one thing that would be particularly notable is that dexmedetomidine is a little bit less likely to affect your CPP versus, say, a high dose of propofol or pentofarb. So maybe that could be something that drives that.
Yeah, no, so they didn't report their CPP, which was also interesting.
Yeah, awesome. And so Josephine has two questions in the chat for you. So the first one is that your current institution is dexmedetomidine restricted, and would you suggest it as a first-line agent in TBI patients? And then second, do you currently utilize a premix, bottle, or bag, or do you compound it from vials for cost-saving measures?
Yeah, so at our institution, dexmedetomidine is not restricted. And while I wouldn't suggest it as first-line agent in TBI patients, just because we don't have great data on it, I think there's still debate on if it will be beneficial in TBI patients as a second-line agent. So while we use it for sympathetic storming in our neuro ICU often, looking at patients in a more septic type picture, they did a secondary analysis that found that these patients actually had increased mortality on both propofol and Precedex in younger male patients, which is what we think of as like our typical trauma patients. So I think even though that's like in a septic shock picture, which is different than a TBI picture, I think it would be just interesting and something to keep in mind when you're looking at our patient population. And we use the premixed bottles, which are more costly here.
Yeah, likewise, we don't have it as a restricted agent here at MGH. I mean, we have premix bags, but essentially the same idea. And interesting, we use Precedex first line quite frequently, but typically, and one of the unique things about the studies, as you previously pointed out, is that the exact definition of moderate to severe TBI is quite important. And so we will oftentimes use dexmedetomidine up front for less sick patients, which obviously is a potential confounder here that it sounds like they tried to account for with some of their propensity score matching. Fantastic. Are there any other questions from the audience for our presenter? All right, well, hearing none, Dr. Saber, thank you so much for reviewing this data with us, and thank you everyone for tuning in to the May edition of the NCS Pharmacy Journal Club. Again, feel free to keep going with the discussion on Twitter we're using the hashtag NCSPharmJC, and hopefully we will see you next time for our next Pharmacy Journal Club. Thank you so much.